End-of-life care in dementia does follow a particular curve. So there's a publication on the 4 end-of-life curves that we commonly see in the United States. The 4th and most common is the frailty curve, and that is most often the end-of-life experience for people living with dementia. One of the actually helpful things in a dementia syndrome is that we have a relatively common and well-trod path that we can anticipate what that journey is going to look like. Meaning we have indicators, clinical signs that this person is most likely looking at their last 6 months of life. We've been staging, if you've been following this patient clinically during the journey, you're staging them throughout this course of illness, and we're aware when we are at that late stage and then terminal stage. One of the beneficial things of following a known disease trajectory is that hopefully you're partnered with a clinician who can give you anticipatory guidance along the way. Anticipatory guidance may be billed and look like something called advanced care planning, meaning this is where we are today at any stage of this illness. This is what I am concerned about over the next 6 months or 12 months as the clinician. I often ask the patient and care partner, what are they considering over the next 6 months or 12 months? So that we can consider what might come up, and then we can already have considered how we might want to address it. End-of-life care in that sort of circumstance can lead to what we call a good death. So when you begin the conversation understanding we all have an end-of-life experience, what would a good end of life look like for you? We have that opportunity to talk about what that looks like. Is that at home? Is it with hospice? Is it in a facility? Who is there? Sometimes I ask patients or care partners, depending on where we are in the disease, paint the picture for me. If we're talking about a scene in a movie, who is in the scene? What is the setting? So in that way, end-of-life care for people living with dementia may be different than for someone, for example, who has a very sudden and significant decline from a very advanced cancer that's found at late stages, for example, or from something like organ failure. What you have to keep in mind, though, is people living with dementia don't necessarily only have dementia syndrome. We're talking about older adults, many of whom have 3 or more chronic conditions, and so there may be an interplay of those conditions with their dementia. For me, that's why I believe that all care in one place is the most helpful thing, so that you get an end-of-life experience that is as close to what they were hoping for as possible. That's important for the person. It's very important for the people who are the survivors, because they are going to reflect back on that experience. So in that way, dementia care at end of life may look different if you have the opportunity to plan ahead with a clinician who can both tell you what is feasible and realistic, but also do that with compassion. Neuropsychiatric symptoms may be a factor at end of life. It really depends on the patient. Most commonly, very active neuropsychiatric symptoms are in that moderate or late moderate stage. In later terminal dementia, many times people are less verbal and less physically active, and so we should not assume they are not experiencing neuropsychiatric symptoms, but they may be less obvious. There is, of course, a concern for things like terminal delirium. So very end of life, families are concerned that this is going to happen, that there will be this acute confusion. Sometimes people do have hallucinations in those last few days. That's different. Typically, we think of that differently than a vivid visual hallucination that has happened in the moderate stage of the disease. Sometimes people have hallucinations as though they can see relatives, or they're anticipating what's happening next if they believe in an afterlife. They may have false beliefs about that. It may be positive. Not all delusions are frightening. So it can be a concern for people. I think it's, again, a good reason that you're managing both psychosocial and biomedical symptoms around that end-of-life experience. So when you're creating a care plan for someone living with dementia and or their family care partner, the number one thing that you begin with is always, what matters most to them? And you should feel comfortable asking that question again over different time points, because what matters most to us changes and evolves as we change and as circumstances change. So we begin with their goals, and those goals may fall into certain categories. They may be very interested in a particular physical goal, a blood pressure that's at goal, or a hemoglobin A1C that's lower, because they feel better and their thinking is probably more clear when they're not, having such high blood glucoses. It may be something that is more about relationships. Many of our patients, when we ask them what matters most to them, will tell us that what matters is their connection to friends and family, which of course was a huge challenge during the pandemic because that was a major loss for many people, was that connection. And while we tried to make up for that through electronic means, it just wasn't the same as human touch and intimacy. So we begin with what matters most, and then your job as a clinician is to try to manage their health so that they can engage in the thing that really matters to them. Sometimes in healthcare, we feel like we're at the center stage, in particular for people with multiple chronic conditions. But in reality, we are a supporting role. Our role is to make sure that they have the capacity and the ability to do the things they want to do for as long as possible. That said, in a care plan that I write for my patients, it does include their health problems or health concerns. It also includes instructions, very specific instructions that I have for them, things that are actionable that they can work on a daily or weekly or monthly basis. It outlines neuropsychiatric symptoms that they may be experiencing and a list of, again, practical strategies that they can put in place that may be helpful for reducing or preventing or treating those symptoms. And then, of course, in a care plan, you want to make sure people know all of the team members involved in their care. That may be your medical care, it may be community-based agencies, and it may be the neighbor. So we need to know who's on the team, who's part of their village. And then we want to make sure they know what the red flags are that we're watching for. So if these things come up, here's what I want you to do, and here's when I want you to contact us. And of course, as a medical practice, make yourself accessible when they need to contact you.